people are really much more likely to go in debt nowadays. The greed has ossified. And I was really surprised by what I saw up close. I was like, wow, these bills every day. You can't get anybody on the telephone. You can't get an answer. The minute you have a diagnosis, draft a team for yourself.
Okay, so if I had to ask you one piece of legal advice you would give to any patient, what is it? Hi, everyone. This is Samira Daswani, the host of the podcast, The Patient from Hell. I have one of the most diverse guests I have ever met in the cancer world. Rebecca, welcome.
Thank you so much.
Rebecca, so I'm going to do a very brief intro, but I would love for you to introduce yourself after I do that. The reason I said diverse is because you've done law, you're an author, you're an advocate, you're in pink, and I'm going to ask you why. You should probably tell us at some point. But you've been one of the, we met almost, 9 months ago now?
Yes.
BACC conference?
It
Yes.
was, yeah.
Yeah, look at that.
At Oracle.
I remember just being floored by how incredible you are and all the work you've done for the community. So with that intro, do you want to tell us a bit more?
That is so nice of you to say. Thank you so much, Samira. And I feel the same. So yeah, I'll just talk to you quickly about how I got to be who I am. I had this esoteric legal background that involved ninja skills that I didn't really know were so useful. I chose to pay off my student loans by trying to find something human inside of big law. That's really how I got there. So I thought, okay, human resources, employee benefits, those are people, not bonds, not debentures. I still don't really know what that is. Like that. I just thought this would be something I could stand while I was paying off my student loans. And I learned a lot of really interesting things. I learned about health insurance. I learned about compensation. I learned about the workplace being kind of a quasi safety net in a certain way in this country. And I think that's really true. And a lot of those things aren't even necessarily portable from one job to the next, though they probably should be. Cut to my husband and I moved with our very small child to Silicon Valley for the reasons people move to Silicon Valley. And back in New York, my mother is diagnosed with breast cancer. I grew up in a cancer cluster, I would say. It's one of those places, high in Ashkenazi Jews and BRCA, et cetera. I went home with my little kid to try to see what I could do to make my mom's journey smooth, just to see how I could help. And I wasn't working full-time for anybody else at the time. I was working as a consultant for myself. So I was able to do that, which was great. Pre-COVID, the idea that you could work from anywhere was kind of a crazy thing, right? But I was. So I did, and that was really lucky. And I was really surprised by what I saw up close. I was like, wow, these bills every day. You can't get anybody on the telephone. You can't get an answer. You're given these choices about what to do next when you don't really know the answer. And who do you ask? And how do you get to that person? And why does everything take so long? And, how is it possible that one day you can think it's X and then the next day it turns out to be Y? Or you even are told, we're going to be doing this for you. And then you get there and they go, oh, well, your records say we're doing that. All these things happen along the way and they're so destabilizing and difficult and surprising when you've got a decent circumstance. Like my mother was married to my dad. He's a lawyer. They had good health insurance by most measures. They had reasonable financial security. A lot of those things that add extra pressure weren't even there. And yet, what a huge maze. So I go home to Menlo Park, Palo Alto area, and I find this place that was then called Community Breast Health Project. It's now BACC. And this was over 26 years ago. And I get a meeting with the ED and I say, hey, I've got this very strange legal background. Like it's less than 1% of all the lawyers in big law strange, and I didn't really ever anticipate thinking about using it in the way that I'm wondering if I can, but do you think your clients could benefit from some of this information that I have? Could I possibly be of assistance when they're navigating this complicated thing, which is more than one thing? It's not just health, the health space. It's the workplace. It's all these, it's insurance, but it's also other employee benefits and rules and regulations. And what do I do and who do I ask? And could I help? And the lady laughed. She couldn't believe I was asking that question because, again, it's a very small percentage of lawyers who actually have that training. So it was just one of those things that happened. And I started working with women there. Then less than 5 years later, my sister was diagnosed with also breast cancer, although it turned out to be non-BRCA. And we don't have BRCA in my family, but we have a lot of breast cancer. Nonetheless, her cancer was actually different from my mother's. Either way, what was a moderate risk journey turned into a high risk one for me. And I've got 2 daughters who are now adults. So all these things just made me want to double down on all of this work. And that's how I got there. At the same time, I was also working as a storytelling coach because I've always loved editing and writing. And so all of this stuff just kind of came together. And that's how I ended up writing a book. There's even a longer story. But I also just felt like we're at a moment, a real flexion point where I don't want to hoard this information. I want to share it as widely as I possibly can.
We should get into the book. But before we get into the book, you've been seeing this play out for 26 years.
Yeah.
That's a long time.
It sure is. That's a long time to stay with one organization, too. That says a lot about BACC and their culture, doesn't it?
It really does. And the impact and the sustained impact they've had in the community. Rebecca, given that you've seen it for 26 years, what's changed?
Well, really a lot has changed. In the early days before the ACA, some people call it popularly Obamacare. Some people argue about whether or not that's a nice thing to call it. And some people say, is the A for affordable really true? And maybe not so much, and maybe less so now that it once was or as envisioned. But there was a lot more angst around staying covered or getting covered because of the pre-existing conditions rules. People were flipped out about if they ever lost group coverage. If you had group coverage and you had no gaps, then you didn't have to worry about pre-existing conditions. But gaps happen. But then if you were a person who had individual coverage, it was really difficult. And there were these pools you had to go in for major risk insurance and things like that. And it was such a headache and you could never get in fast. So there was a wait list for that. People were doing things that were so complicated, like joining groups just to get group health insurance, creating businesses around things that they really were freelancers for, just so they could be a buying group. Things like that have gone away. That's a big difference. Another difference I do see, though, and that one was a good one. This one is not as good, is that people are really much more likely to go in debt nowadays. The greed has ossified. There's so many new stakeholders, new companies, new things that have to happen that ultimately trickle down to the patient having to pay for them. And you see that in a lot of cases in a lot of ways. The third thing I would say is, despite a lot of the doom and gloom that we're hearing about now, research has marched on. I mean, 99% of women who have an early detection of breast cancer are surviving and thriving. That wasn't true when I started this. So, I know there's some tough stuff in the air, but when I look at that, I still feel it's a systemic big win.
Yeah, I definitely agree. That one I definitely agree with. You did say something that I want to double click on. You said greed has ossified.
Yeah.
That was more.
Well, the system always ran on dollars, but I think that somewhere in there was that basic idea that medicine is about healing. I mean, old timey wimey doctors made house calls, right? Things were different. There's a really, I would say, I don't know exactly when the medical industrial complex was birthed, but it is a complex now. There's just, things over things over things, layers and layers deep of bureaucracy, of business, of who's skimming off the top and how. With progress comes people jumping on to take their piece. And you see that. I mean, look, biotech is great. Device companies are great. They do wonderful things. Of course they do. But there's also the fact that things are being more and more monetized.
So my question for you is, you use this analogy when describing, I think, your mom's case. And I think you said it was very destabilizing, even though you had good circumstances and you had to figure out that maze. That was 26 years ago. You talk to patients today, we are seeing in breast cancer a wonderful overall outcome for life. Has that maze gotten more complicated or less?
Oh, it's more complicated anyway, I think. And I think if you look at the tech, I think that's a large part of it. Electronic health records are really a tough thing for patients. They're not that great for doctors either. I've talked to a lot of doctors who don't love them. It's really a barrier. It's a communication barrier. And it's got all kinds of weird rules going on. You don't know what you're reading, and they are being told and pushed. If you ask these 3 more questions, you can upbill. There's things going on behind the curtain that people don't know. And I think it makes things more complicated. I do. It's just because outcomes are better doesn't mean that the journey is smoother. It can still be a tough journey.
That's such good. I am so boring, that phrase.
Take it.
That I think that was a very, very nice synopsis of, I think, where we are as a community. I actually very much agree with that statement for what it's worth, but I think it's a very good synopsis. Rebecca, so on that, tell us how your book fits into this larger scheme of life.
Yeah. So, I've written some books before. I've published in different ways. I self-published a cookbook for fun, but I've done some breast cancer books through foundations for employers to try to train and help employers do better with cancer patients. The first book I did was called Breast Cancer in the Workplace. So that one, and I did it with some other women. It was co-authored and I was the editor too. That one was really to say, hey, here's the laws, and then here's the good stuff you can do. You can actually be better than the laws, and here are ways that you can. And by the way, it would be good for you as well, employer, because it is. But this book is different. This book is for the patients. The reason that I wrote it is because I wished it existed. And that's not always a reason to get an agent to say yes to you, by the way. But I eventually did, which was really lucky, and I feel great about that. And I love my agent so much because he shares my vision about all this. But really, there are books by doctors. There are books by celebrity patients, because people, the publishing business wants to publish things that they think will sell, right? That's just how it goes. So you'll get that one story, and you might get some helpful checklists, or you might get the doctor's point of view somewhat, or you might get an economist saying, we really could afford to do a single payer system. We just don't have the political will. Those books exist too. But a book by an advocate that brings together an amalgamation of different stories, diverse. You mentioned the word diverse, and I love that you did. Thank you. Because it's not just my background that's diverse. It's the women that I've worked with. Really. I mean, low-wage jobs to Stanford professors and everything in between, because the system is so complicated, regardless of who you are. And doctors and lawyers too. It's like, if you don't do this every day, you wouldn't want to do it yourself. That type of thing. So I think that what this book gives is this combination of legal and practical savvy based on experience, as well as a wealth of stories that are examples that readers can extrapolate from. It's tricky when you talk to somebody who has the same disease that you have. Sometimes that helps a lot, and sometimes it doesn't help you at all. Sometimes it stresses you out because they want you to do what they did to validate their choice, and that can really make things sticky. So I like the idea of giving people these stories, and they can extrapolate the pieces that help them. That's how women learn anyway, right? We're culture keepers. We love stories. We've been sitting around the fire telling stories from time immemorial, right? Across cultures. So we know that this is what women need. And I wanted that for this book, and that didn't exist. So that's why I wrote it.
So give us one story. Give us one of the stories that really strikes you.
Okay.
It's emotional.
One story really hit me. I got a call one day from BACC, said, there's this woman named Karen, and she recently went on Medicare, and she's dealing with a complicated cancer, and she's got a recurrence, and she was treated at a university health system, and now they don't accept her Medicare and not the carrier she's on. So she's being treated way too slowly, sadly, at a community health center instead, because they take her coverage, like a county hospital. She's an incredible woman. Would you talk to her and see if there's any way you could speed the plow, maybe get her in? She was there before. She was a patient before. It's not quite a continuity of care situation in that it's not the same active treatment cycle, and yet maybe you guys could work together. So I called Karen. What an incredible woman. I mean, just an artist, a writer, a producer, a business person, a brilliant woman, a super capable person, and so kind and so appreciative. Well, we sharpened our pencils, we put our heads together, and we wrote and called and advocated together. We did it together. It was so energizing and wonderful. And inside of 2 weeks, we got her in to the old doctor. We brought the doctor who had treated her before into the mix. And that doctor, we explained the whole situation, and that doctor got on the horn and advocated for her too. And it seemed like it was impossible, because if people tell you this is out of network and it's a no, you never think it's going to work out. It worked out. And I got an email from her shortly thereafter, along with a book of her paintings and poems that she wrote a beautiful dedication to me in the front of. And I have to tell you, this meant so much to me, because when a woman like that says, "You gave me hope when I had none," I don't know. even today, that just gets me. And that's just one story, Samira.
I definitely understand. I very much relate to that. But how? Tell me how. How did you get someone who's being told they're out of network?
So this goes to the insurance beast as in total, right? Everyone is conditioned and trained to say, why not? All levels of the system are ready for the no. There's even automatic denials that probably shouldn't be happening for coverage of things that already happened, like bills, for pre-approvals of things that should happen. Recently I had a woman who couldn't couldn't believe she was denied for pretty standard protocol for breast cancer. And I talked with the doctor, and the doctor said, we've been doing this for 20 years. This is clearly reasonable and customary. So why they would send her a letter saying this isn't reasonable and customary, I feel like she lost the lottery and they just do this randomly. I can't explain it. It feels like a scattershot denial. I have seen this happen a lot of times. People send bills like just under $1,000 that are clearly not right because there's this, I dare you to pay, I dare you to take no for an answer. There's that bias that's baked into the system. So if you just communicate really clearly with the right stakeholders, you choose the right words and you say them to the right people at the right time, you can move the needle. You really can.
I believe you. I'm smiling only because it's what you said. You have to say the right words to the right stakeholder. Means that you need to know the right words and know the right stakeholder.
That's right. Those are the two challenges. But that's what I help people do. Exactly those two.
So Rebecca, tell us, give us an example of what are the right words for the right stakeholder? What's an example of that?
So the right words to the right stakeholder would be, okay, let's, in the case of that story I told, right? How did we do it, right? You asked me. Well, it was a matter of getting the doctor who had been treating the patient to say, this is your patient. This is a case that you started. And we believe that this is a continuity of care situation by virtue of the fact that it's the same person and it's the same disease. So could you see your way to advocating with the health insurer using those words? And that's it. They're magic words, right? They really are magic words. In the workplace, it's a different kind of magic words because in the workplace, I never have ever told somebody that they should actually bring a lawsuit. What a waste of time. When you're on a health journey, you really want to do that? No, you don't. But you know what you want to do? You want to make it clear that you know what the rules are by using the words that echo them. And that way, they listen to that, they see that. What do you think they do? They take it right to their lawyers, and the lawyers go, you know what? Maybe you should just give her 3 months severance instead of doing this, because they see it. Again, it's practical. It's not really legal. It's practical. Everybody's trying to avoid the same thing, which is owing a lot of money for doing something that they shouldn't have done.
What are the magic words to an employer?
It would be things like reasonable accommodation would be a big one. Because that comes right out of the disability discrimination law. So you would say something like that, or you would talk about active treatment is a big phrase, because they don't want to, let's say they don't want to give you, give a patient a longer leave of absence. Mm. Well, a person in active treatment, okay, that's a really different story, right? Like those are the kinds of things, they often will come back and go, well, that would be a hardship. That's their word, because that's the word that they get to carve out being reasonable. They go, well, we can't be reasonable because it's a hardship, right? So you can anticipate they're going to use that word by going, well, there are people in my department who have said that they're more than willing and able to cover for me within reasonable business hours until I'm able to return, like that. And then it's a little harder for them to go, well, that's a hardship, right?
Okay, so if I had to ask you one piece of legal advice you would give to any patient, what is it?
This is a really big deal, especially with women patients. Your benefits are yours. You have earned them. They are part of your compensation package or part of being a citizen, part of paying taxes. There is zero shame in taking the steps that you need to take in order to avail yourself of those benefits. That's a really big deal. I feel I've had to say that many, many times in 26 years. Does that surprise you?
Yes and no. I think it doesn't surprise me that it's more women than men. That doesn't feel surprising.
Yeah.
I think it's very understandable. I mean, I've been in that situation. I was employed. I mean, I've been employed. I didn't take any leave of absence, no FMLA, nothing.
Yeah.
I knew about it, but both my immigration and my health insurance was contingent on me having a job.
Uh-huh.
Which meant that, like, you pushing back on that is you rolling a dice and you not getting treatment at all.
Right.
And
see how those things all fit together.
no, they really do. They really do.
Yeah, that's why holistic, layered advocacy is so necessary. Somebody who understands how these pieces fit together. That's another reason I wrote the book.
I like that you said layered advocacy, because I think that's also important, right? Because you may not, as a patient, I think it's hard because you don't always see them as layered and you don't see them as interconnected, right? It kind of feels like my employer's on one side, my treatment is on the other side. But the reality of the American healthcare system is like, that's just not true.
That's right.
My employer is very much part of my healthcare experience.
That's very true. And on that note, one of the things that I always tell women, which is, on the other side of what would you tell people, it's the minute you have a diagnosis, draft a team for yourself. Think about it the way you would think about it if you were hiring. Okay, you're in charge of a startup. You need to draft a team, right? In order to get your goal. So to have the best healthcare journey, draft a team. And who's included on that team? HR at your company. Or if it's a smaller company, whomever is that person. Maybe it's the COO. If it's a small startup, let's say. Whomever that person is who is making those relationships with all of the benefits, including health insurance, that's a person you want on your team.
100%, Rebecca. I cannot tell you how much I agree with that. It took me a long time. Like, personally, it took me about a year and change to feel comfortable switching jobs.
I understand.
You live in the world of, ACA, and like, that shouldn't be a problem. But
right.
When you switch insurances, everything resets.
That's absolutely true. And people are really fearful of that right now for a lot of reasons. People are really worried about losing their health insurance. I just wrote a blog about this just a couple of days ago. There's a lot you can do to dispel the fear. There are as many steps you can take, and there's a lot of things you may be eligible for that you don't realize you're eligible for, but it's still scary. And one of the things I always tell people is when you're choosing, if you have a choice, you're lucky enough to have a choice, whether that's buying a plan, switching jobs, whatever the case, back into it with who is your medical team. It doesn't really matter if it's great coverage if your medical team doesn't accept that coverage. And I've seen so many people really choke on a bone on that. They think they got it knocked, and then they go, wow, I can't go to my regular doctors unless I want to incur these giant bills.
Oh my God. Yeah, yes.
So, that fear that you mentioned is well-founded.
Oh, oh, trust me. I know. I've had to switch medical teams 3 times because of insurance issues. Once because I switched jobs. Once because, actually, Karen's story happened to me twice, where a doctor who was in network was no longer in network.
Yeah.
And then the system shifts on you, and
it does. And it's like, if you don't happen to call and have an appointment, you don't even know what's going to happen until, you might get like 30 days notice, maybe. I don't know. And this happens more than people talk about. It really is one of those things that happens. And if you think about it from the medical system perspective, look, they're running a business. What do you think they do? Every year, they look at all the contracts they have and they go, oh, those guys didn't pay us very well. Oh, they were arguing with us about this reimbursement and that reimbursement. Oh, let's drop them. They probably drop 1 or 2 every year by rote. They probably have a system where they do that. And then, they re-up some, and then they were always trying someone new because everyone's optimizing.
Exactly. No, 100%. I'm completely with you. The issue with some of these contract renegotiations is that even when they are happening, because they go on for a couple of weeks, right? That they don't happen on the dime.
Right.
You end up in limbo state as well.
It's so stressful. I've seen this happen a lot of times. A friend of mine who's an influencer and a writer about healthcare, specifically on LinkedIn, just wrote about this. You're like, it's like your mom and your dad are getting divorced, but you're not sure. And they're like, going to the mediator, and you don't really know what's going to happen. In the meantime, you're like, where am I going to sleep? That's how it feels. And sometimes it works out at the last minute, and other times it doesn't, but you have to go through the whole journey, because 6 months before they start telling you, well, we're not giving new appointments. What do you mean you're not giving new appointments? I'm a patient here, and that happens. I've seen it happen.
I'm trying to make sure this episode is not super bleak. But yes, I know it happens. Okay, you ready? I'm going to switch to rapid fire. We're going to do insurance myth busting, okay? For rapid fire.
Okay.
I suspect you'll be fine. What is a deductible?
What is a deductible? A deductible is an amount that is a ceiling of money that you have to pay out before you can recover. So you basically have to spend that much before you're going to get covered.
What is out-of-pocket maximum?
An out-of-pocket maximum is, you're going to have co-payments. You're going to have all these expenses, even though you have coverage. So an out-of-pocket maximum is a ceiling on how much you can spend. After that, they'll cover you. But it's usually a pretty hefty number.
What is FMLA?
The Family Medical Leave Act. Oh my God, this is so stressful.
Tell us what that means.
So the Family Medical Leave Act is basically a law. It's a federal law, but there are also state correlative laws that differ ever so slightly. And sometimes it's just about the size of the employer that makes you be under one as opposed to the other. But it's basically a law that says if you have an illness, you can take up to 12 weeks off, assuming you've been employed for a whole year, which sometimes people get hung up on that. It doesn't have to be 12 weeks in a row. It can be at different moments. A lot of people don't know that, but it's true. And usually you would take your PTO or vacation pay first, but after that, it's unpaid leave. That said, you might have short-term disability that you can be doing for income replacement at the same time, but that's under a different scheme. And the big thing about Family Medical Leave Act that a lot of people talk about and worry about is they're supposed to keep your job open for that, the duration of that 12 weeks. And, there's some nuance there. Like they could offer you an equivalent position if they'd had to backfill yours. And sometimes that's where you'll see a hardship come into. An employer will be like, well, you know what? We needed a project manager to manage that project. And now we don't have that job, but we have a different job. So we'll give you that.
Super helpful. Okay. Short-term disability. What is that?
So short-term disability, and I think it's usually 26 weeks. And this is usually a private pay plan. This is not a government plan. It gives a patient a chance to take time off with pay for that period of time while they're in active treatment and potentially some recovery as well. It's usually a bit higher in terms of the amount of pay than longer-term disability.
Okay, what is longer-term disability?
So long-term disability generally kicks in after short-term disability. And again, not all employers even do provide this. A lot of people just have to deal with SSDI, which is the government disability. But long-term disability is for people whose illnesses and treatments are lasting longer than that time. The definitions of disability can differ under each of these plans, which is another thing people don't really deal with until they have to. But one thing I will say that I think is really upbeat and positive and helpful, doctors are excellent at filling out these forms. Their offices, usually, it's not necessarily the doctor, him or herself, but they do it every day. And so when you ask for help, you're always like, oh my goodness, can you help me? But the truth is, they know how to help you. Let them help you. They do it all the time. So to qualify for these various disabilities, it can be a bit of a hill to climb for folks, especially SSDI. It's the hardest and it takes the longest. But these sort of privately funded disability plans tend to be reasonably efficient and tend to pay people quickly. And, again, doctors are trained in helping people deal with this stuff.
Okay. Super helpful. All right. What about leave of absence?
So leave of absence can mean a lot of things. We just talked about it in the context of FMLA. A leave of absence is it can be paid, it can be unpaid. Think of maternity leave. That's a paid leave of absence. There are some employers will give you a paid leave of absence for an illness or for caregiving as well. It just depends on the benefits that are provided. But again, the idea of it is we want you to be well. We want you to come back. We want to support you. That's the ethos of having a leave of absence program.
All right. Let's go to COBRA.
Okay. COBRA. Do I have to say what it stands for? Because I'm not sure. I might lose points on this one. The consolidated blah, 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 blah. So COBRA is a very important law that was passed in the 80s, I believe. And the thing about COBRA is it allows you to continue your group health insurance coverage. Now, that doesn't help you if you have an ACA plan, an individual plan at all. And it also doesn't help you if money's so tight, because the essence of COBRA is you get to continue on the same group health insurance plan. And the great part of that, of course, more than anything else, is that you get to have that continuity of care with your same medical team. And that's a big deal. But let's be honest, it's expensive. I can't give you an exact number because it depends completely on the base plan that it's an outgrowth of. But that can be a stopping point for folks. Like if you're at this moment where you're going, well, I have to go on unpaid leave. Well, I don't know, if I'm going to get any disability pay, or if I am, when. And then you go, well, but you're going to have to come up with X dollars per month all of a sudden. It might not be that simple.
What?
But it's also the cleanest way to stay insured if you can do it.
Okay, so I'm going to play this back to you because we covered a bunch of them. I'm sure this is not comprehensive, but what would help me a lot right now was sequencing it, because you have sick leave, PTO, which is paid leave. Then you have short-term disability, may or may not be available, but if it is available, could be really good.
Yes.
Long-term disability, which is government run.
Not always. Sometimes companies will have LTD plans as well, long-term disability plans. Yeah.
FMLA, SSDI.
Yes.
Then we have COBRA.
Yes. SSDI, by the way, is Social Security Disability Insurance. That's what it stands for. That one I know.
And then we have COBRA.
Yeah.
All right. Oh my God. Okay, so I, at least before our conversation, didn't realize we had all of those options.
Absolutely. Yeah. Yeah. Depending on your employer, you do. Yeah. And there are other things too. People don't realize that there are other ways to get benefits. Like, first of all, a lot of workplaces, they have sick time sharing programs where people who don't need it will give the days so you can have extra paid sick time. People bank their sick time, but they also donate their sick time. That's one thing. Another thing is there are EAP plans. Let's say you're having some mental health issues. People have mental health issues when they're dealing with illness, more often than not, I would say, right? There are plans for that you might not realize you even have. there's all kinds of wellness apps and other stuff also that are part of big employee benefit programs. But there are also ways to get value out of things. You could have a life insurance policy that has either a cash value or possibly a suspension of premiums while you're ill, where that means you're still covered with life insurance, but you don't have to pay for the premiums. There are things like that. You can take hardship distributions sometimes from your 401k plans if you need some cash. There's all this stuff people don't realize they can look at. That's why I say get to know that HR person or COO, as the case may be.
I very much appreciate this. Okay. All right. If you could, I'm going to switch now into closing out because as I told you before we start recording, we can probably do 9 hours of this. But for this session,
okay.
If you could change one thing about the healthcare system, what is it?
That's easy. Less greed, more healing. The incentives are just way too much about money. We're allowing third-party payers way too much influence on what becomes the standard of care. We're letting other third parties extract outsized money from the system, and ultimately it's patients who pay. And I just don't think it should be that way.
Being a patient, fill in the blanks for me. Being a patient from hell means
being empowered to ask the right questions, anticipate the potholes, and communicate with clarity and directness. Look out, we're coming. That's a patient from hell.
All right, if listeners remember one thing from this episode, what is it?
No woman needs to go on a health journey alone because help is available. We actually have a lot of what we need to make things a lot better, even inside a system that clearly wasn't built for us.
Rebecca, thank you so much.
Thank you so much.
I am very, very happy to have known you, and I have learned so much from you. And thank you for sharing all of this wisdom with the community.
Thank you so much.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The opinions of the speakers are their own and do not represent the opinions of organizations they're affiliated with, nor do they reflect the opinions of MantaCares Inc. or MantaCares' sponsors.